Okay.
So by the time start kar lete hain. I also request
Right.
now Dr. Latika Bhalla, Senior Consultant Pediatrician at Sir Gangaram Hospital and President of IAP Delhi, to say a few words before we restart the session. To Dr. Latika Bhalla, please.
Anji, thank you, Dr. Pankaj. New Year greetings to everyone. I feel privileged to invite all my colleagues and seniors to this first CME meeting. I'm really thankful to Dr. Deepa Gautam and Dr. Pankaj for giving us an opportunity to interact with everyone on Delhi IAP platform. 24th National Girl Child Day is celebrated on 24th of January, and it was initiated by Ministry of Women and Child Development in 2008 to spread awareness about gender-based discrimination that girls face in our society, and of course, to bring change in attitude towards the girls. Similarly, we have an International Girl Child Day, which is celebrated on 11th of October, which just started as a project of Plan International initiative, because I am a girl campaign, and which was inducted in United Nations by Rona Ambrose, a Minister of Canadian Women at that time, in the year 2012. This probably deals with inequality in access to education, nutrition, legal rights, medical care, violence against women, and forced child marriages. Each year have a different kind of a theme. And the first theme in 2012 was ending the child marriage. And this year, we have a theme for year 21-22 is digital generation, our generation. COVID adolescent vaccination is important from adolescents as well as all the children, and much needed step for education and rehabilitation of children who are not able to attend the school for last 2 to 3 years. So this will be a great step in stabilizing all the adolescent children. And that is why we are dealing with COVID vaccination on the day of Save the Girl Child. And over to Dr. Sangeeta Yadav and Dr. Dhiren for giving us a very lucid talk and discuss the topic at length. Thank you so much.
So thank you, Dr. Latika, for your information regarding the Save the Girl Child Day. So now we start with the academic session. We have with us Dr. Shyam Kukreja. Dr. Shyam Kukreja is the head of department of pediatrics at Max Patganj, and he is also a very senior member of IAP Delhi, as well as his keen interest in infectious diseases makes him the best person to moderate and chair this session, which is being taken by Dr. Dhiren Gupta on COVID issues in adults and vaccines. So I'll request Dr. Shyam Kukreja to say a few words about the topic and speaker, and then we can request Dr. Dhiren to start the presentation. Over to Dr. Shyam Kukreja, please.
Thank you. Welcome you all. I think we have been going through different phases of pandemic. It was first Alpha, then we went through Delta wave, now we are going through Omicron wave. And the different phases gave us different challenges, which we have managed adequately. I think Dr. Dhiren is going to speak on this subject and how this Omicron has been very different from Delta wave. What have been the issues regarding this Omicron as far as our practice is concerned? And then I think after 15 minutes, maybe we'll discuss questions as posed by you and discuss these questions regarding vaccination of adolescents. Over to Dr. Dhiren. Dhiren, all of you know, is a senior intensivist and a well-known pediatrician in the city of Delhi. He is attached to Gangaram Hospital, and he'll be speaking on this subject. Over to Dhiren.
So I can, Dr. Dhiren, Dr. Dhiren, are you on the platform? I can't see you. Dr. Dhiren, are you there on the platform? I can't see him.
Till then, Dr. Deepa can say a few words as a secretary AHA.
Sure.
Right. So by the time I'll try to contact Dr. Dhiren.
Okay. And good afternoon, everyone. And Happy New Year and Happy Makar Sankranti and all happy new CMEs for this year to every one of you. Well, little adding on to what Dr. Latika said, The National Save the Girl Child is celebrated every year on 24th of January, and its inception was done in year 2008 because of the installation of the Prime Minister Indira Gandhi for the women empowerment. She was sworn for the prime ministership on this day. That is why, since that time, it is being celebrated as a National Save the Girl Child. And the theme for this year is in India is a world without girl is impossible as a world without water. And the objectives are basically to make the child aware about their rights, make them aware about the Domestic Violence Act, prohibition of the Child Marriage Act, dowry prohibition law, make people aware of discrimination faced by girl child in the country, to propagate gender equality, generate awareness about the need for girl education, health, nutrition, even the hidden hunger like anemia and the micronutrient deficiencies, and also respect. To make environment around the girl child positive, that is to increase the confidence level, to enable them to think critically and to be economically independent. And the various schemes launched by the government of India for this particular day have been Beti Bachao, Beti Padhao, which was launched way back in 2015, and then followed by Sukanya Samriddhi Yojana, which was a good investment plan for girl children below the age of 10 years to save for higher education or marriage. Next was Balika Samriddhi Yojana, which is a scholarship program which is to aim to provide financial help to the girl child and their mother. The CBSE Udan scheme, which has been launched by the Ministry of Human Resource of Development, and this ensures the enrollment of the girls in engineering or technical colleges over the year over India. The Dhanlakshmi scheme, which was launched, and the national there are various scientific Sabla scheme, which is a midday meal program and providing bi-weekly folic acid and biannual deworming, and the Khelo India scheme, which are the scholarships for the women scientists and scholarships and fellowships. And I would add to this by saying that when you empower a girl, you are empowering a friend, a wife, a sister, a mother, and a daughter. So every man needs a mother, sister, then why not a daughter? Boisterous as wind, playful as balloon, please don't kill the little butterfly in her cocoon. Daughters are angels sent from above to fill our heart with unending love. With these words, I hand over to Dr. Dhiren if he has joined in. Has he joined in, Dr. Dhiren?
Dr. Pankaj, please take over.
I just talked to Dr. Dhiren. He's joining immediately.
Okay, fine.
We're trying to get in touch with him. So I think I can request Dr. Sangeeta Yadav to make her presentation, which is also very much related to this only. So may I request Dr. Sangeeta Madam to please share her presentation?
Can you just give me a minute? Just a minute. Yeah, I'll just do that. I'm all set. I'm just opening. I'm just opening the presentation. Just a minute.
Sure, ma'am. Sure, ma'am.
Actually, too many windows were open.
Dr. Dharian has joined in. Dr. Pankaj?
Yeah. Dr. Dhiren, yeah, you have joined. So, Dr. Sangeeta, yeah, Dr. Madam has already started her presentation. So, Dr. Ma'am, Dr. Dhiren has joined. So, should we request Dr. Dhiren to do her presentation first, or you will do it first? Hello. So, can I request?
Ma'am,
Yeah,
please.
Dr. Ma'am.
He's already started, Dr.
Okay, sure. Then let her, Dr. Sangeeta.
Let her continue.
Yeah, no problem. Yeah, ma'am, it's visible now. Hello.
Dr. Sangeeta, you are muted. Please unmute yourself.
The video was also off.
Yeah. Now it is on.
Actually, what happened, because the slides were visible, so then I thought perhaps, I'm very sorry about that.
Ma'am, put it onto your slideshow. Thank you.
Yeah. So once again, I begin, and thank you very much, IAP Delhi, Dr. Deepak Gautam and Dr. Pankaj, and Dr. Latika and Dr. Deepa Basi for organizing this wonderful program related to COVID vaccine. Though very rightly pointed out by Latika and Dr. Deepa Basi that the topic is a little offbeat from what we are actually the day is today. But anyways, it is meant for the children of this great nation. So it's all right. And the current issue is, of course, COVID and the vaccinations which are there. So anyways, I've got a little different and an offbeat topic, though we are all aware of it in our clinical practice, related to this topic of adolescent vaccination in the adolescents and its concerns, especially in children who have got comorbidities. I will not be talking much about COVID-19 vaccine, which Dr. Dhiren Gupta and Shyam Kukreja would be discussing, because that is actually the global talk related to the COVID-19 vaccines, and especially for the from the children's point of view, since now the COVID-19 vaccine has been made available for the adolescent age group and is moving downward towards the lower age groups of children. And they will be talking a little bit about the morbidity patterns which have been observed related to COVID in the childhood population, that is childhood come adolescent. But here I will be talking more in relation to in our clinical practice when we encounter some of these children who have got comorbidities, long-term diseases, and what should be done related to their immunization. So that's what it is going to be there. And I do not know how to get this move to the bottom. That is better. So I begin with our Indian Academy of Pediatrics vaccination schedule, and I would like to bring your attention towards this blue part because that is actually vaccines in special situations and how these vaccines continue from infancy till they are adolescents, and similarly for the other vaccines which are used in special situations, which are rota and also the influenza vaccines, which have to be used in certain special situations related to adolescents. And the most important question is that whenever why I have put this slide? I have put this slide basically because in our clinical practice, most of you are in having your own practice. So we always check on the very fact that whether the child which is being brought to us is up to date with all the recommended vaccines, and if not, then we recommend them. And that becomes more important because you do not anticipate when a child will develop type 1 diabetes, or when the child will develop GBS, or when the child will develop an autoimmune disorder. So as far as asthma is concerned, hemophilia is concerned, some of these diseases have their onset during childhood period, and we must ensure that they are properly vaccinated, and that is what needs to be done. And this is the dictum, that they should all receive their recommended vaccines timely. And we all know that vaccines are not just for young children, but the adolescents also need to be protected, especially related to HPV vaccine, influenza vaccine, whooping cough. This is very important, especially if there is an associated neuromorbidity, and also the meningococcal disease. So IAP had also recommended some vaccination for bigger children if they have missed. And we are all aware of the fact that these vaccines, these routine vaccines, the series should be completed if they have not been done earlier, and especially before they enter into the adolescent age group. And these vaccines on the lower part are also very important, especially for children who are in the high risk group. So we must ensure this vaccination for them. So next question which arises, which is related to the topic about which I've been assigned, that do you have a chronic medical condition? If there is any chronic medical condition, an immunocompetent with chronic diseases should be immunized both with live and inactivated vaccines according to the routine immunization schedules from where I began. So we should know what needs to be done if a person is having an autoimmune disorder, or is having some asthma, or is having some respiratory illness, or is obese, or is having diabetes. So in these conditions, what do we need to do? So coming to the topic, vaccination concerns for an adolescent with comorbidity, that is the topic. So what are the concerns for an adolescent with comorbidity? I'm going to address this thing as, why do I need vaccine, and which vaccines do I need? What are the specific concerns of the adolescent? And in various situations which we see in our clinical practice, I'll be talking about case-based, and finally the take-home messages. So chronic condition is anything which is related to a disease which is lasting for more than 3 months, and we are all aware of the fact that the asthma or splenectomy, asplenia, chronic renal, any of the chronic lung, heart or liver disease, or any neurological disorders, and also the endocrine and metabolic disorders and autoimmune conditions, and all these we need to take care of the immunization. And the incidence of the chronic illnesses has been increasing ever since the turn of this century in more significantly. And we all know that these children need to be protected, since now a lot of the quality, we are actually more concerned about the quality of life. So in the asthmatics, in the cancer patients, in the children with heart disease, juvenile diabetes, in epilepsy, in various conditions, we need to address this issue of vaccination. And the risk is more severe when infection occurs in these children with chronic diseases, and they are more prone to infections because of their nosocomial exposure, because of their visits to the hospitals and their admissions in the hospitals. So ideally, vaccination is best accomplished early when the response is likely to be similar to other persons of a similar age with no chronic medical condition. Like I said, we must ensure the routine immunization of each and every child. And I know we are all sincere and committed towards it. And we always ask the patients we send reminders to our patient and the clientele that they must come and take their immunization. Just God forbid, if some other illness befalls. So vaccines may be less immunogenic in this population, and additional vaccines and additional doses and higher dosages of vaccines are required to provide adequate protection in these children with comorbid conditions. And once the disease progresses and immunotherapy, suppressive therapy is required, then the whole requirement and the recommendations change. So the risk of infections is definitely more amongst the asthmatic, amongst the diabetics, amongst the HIV patients. And some of these patients are also on immunosuppressive drugs and steroids as well. So these things have to be taken care of. So what is the concern specific to the adolescents? So definitely cost is one big factor for the parents, and they avoid taking certain vaccines, and they will come and ask you, Doctor साहब इस इंजेक्शन की वाकई जरूरत है, मेरे बच्चा उसके बिना नहीं, my child can be kept protected without this vaccine. Then many times there are missed opportunities, there are missed visits, parents do not take them because something else takes up the priority. Then at times there is poor knowledge of immunization, the indications and contraindications. They also have a big doubt about whether this vaccine will work in their child or not. And recently, because of the COVID vaccination, our whole global population has become much more wiser and is more inquisitive and more curious about the vaccine requirement, their safety and all, and which has also led to the fear of adverse events and vaccine hesitancy. So the most important strategy for the adolescent vaccination is definitely we need to have multiple stakeholders, motivational drivers, political will, especially for the adolescent population. For other vaccines has been rather low. It is important for communications, proper messages as per the age group, and more important is that the information, especially for the adolescents, has to be a little evidence-based and youth-friendly manner. So vaccination is challenging in this age group, and because of its efficacy, safety, a lot of data is available when we go towards, when we do the literature search, and we find that these vaccines, they are used without risk, but patients who are most at risk for infectious morbidity and mortality, and they're at times in severely immunosuppressed state, are least likely to respond to vaccination. But the dictum is that the vaccination against pneumococcus, Haemophilus and influenza are very important, and live vaccines also need to be given to these patients. I'll just discuss a few scenarios. Very commonly we have this asthmatic coming to our clinic, a thalassaemic, we are following up, a patient who needs a splenectomy, a hemophilic, a nephrotic, a child with chronic kidney disease, and I had this commonly my cohort of diabetics, then chronic liver disease, and these are the various situations where vaccination is of concern and we need to address this issue. So which vaccines do I need? They all need to be vaccinated. Flu vaccines every year, pneumococcal vaccines, depending on the situation, whether we need to give conjugated, followed by the polysaccharide, hepatitis B, A, DDAP, and meningococcal vaccines. These are the ones which are commonly used. Infection can cause substantial respiratory morbidity in children, especially with chronic disease, especially the asthma. There are greater episodes, attacks, and complications. And we all know, though we are right now on online classes, but earlier, and we shall soon be moving towards opening up of the schools, and all these chronic conditions as it is add on to their missed school days. So, Dr. Sab, what should I do about my 10-year-old child who's asthmatic? Have I missed any vaccination? I know I've been coming quite regularly for the management of my child, but every time this child gets the viral infection, there is an exacerbation of the asthma. So we have to ensure that they are getting their influenza vaccines regularly. Pneumococcal vaccine has to be recommended. We give the conjugated form, and later on we can give the polysaccharide forms. So asthma control should be optimized before we give any vaccine. That is what is important, and especially if they are on steroids, especially a higher dose of steroid for more than 2 weeks, then we need to have a little gap before we embark on their immunization for these children. So although vaccination against influenza does not reduce or shorten the asthma exacerbations, but it definitely improves the quality of life and reduces the complications related to influenza. And any child who's having any chronic lung disorder, cystic fibrosis, though relatively less commonly seen, but all these chronic lung disorders need these vaccines. Similarly, a thalassemic who has been part of our clinic, also we must ensure the routine immunization, and any child with anemia or hemoglobinopathy should receive their influenza vaccines annually. And since they are getting repeated transfusions, we must ensure their hepatitis A and B vaccination also. Similarly, if your child from the clinic, we have planned a splenectomy because of hypersplenism, then we must ensure and complete their all routine immunization. But in addition, we need to advise Hib vaccination, meningococcal vaccination, and pneumococcal, because these children are more susceptible to these encapsulated bacteria. And of course, we have to ensure hepatitis A and B. Similarly, if a child presents with some renal disorder, especially the nephrotics, we must, because of the loss of the antibodies, and the chronic renal diseases may have mild T cell function defect, and therefore they are all at greater risk of infections. We must ensure the routine vaccination, which are universally, what is important is the annual influenza vaccine, hepatitis B, and the pneumococcal vaccine. And especially if they have impaired renal function, then they have less than optimal response to immunization, and higher vaccine doses and reimmunization is required. And I will be showing you some of the a lot of literature is available, but I'll just show you the, 2 or 3 studies which have been published from our own department related to these kind of patients as to their requirement of routine immunization and what needs to be done about that. The other is my type 1 diabetic, a 12-year-old girl. The parents were initially, they said कि डॉक्टर साहब आजकल तो बहुत नए इंजेक्शन बच्चों को वैक्सीन्स लग रही हैं, तो क्या मेरे बच्चे के लिए भी कुछ डायबिटीज के लिए कुछ स्पेशल इंजेक्शन वैक्सीनेशन देने की जरूरत है? So therefore, our answer is that these children should, besides the routine immunization, should receive the pneumococcal vaccines. And similarly, children with obesity and with metabolic disorders, also we need to recommend routine annual influenza vaccination. Especially now, children with chronic liver disease. In these situations, there is impaired phagocyte defects and opsonizing antibodies, and there is splenic dysfunction also in addition. So these are the children who definitely need hepatitis A and B vaccines, because if they get on top of the chronic liver disease, if they acquire an hepatitis A or B infection, then they are going to have a more severe disease with hepatic decompensation. So again, the dictum is same, that there is less than optimal response to immunization, and higher vaccine doses and reimmunization is required. Similarly, for the hemophilics, in the hemophilics, the question is whether one should give intramuscular injections to these children or not, because many of these vaccines, they are to be given IM to these children, and these children can develop a hematoma, and that is the time during their infancy, maybe that is the time you have undiagnosed bleeding disorder, and you have to take care of their immunization. So prior to immunization, we must minimize the risk of bleeding, and we should take care of that. And at times, some of the children are also on long-term anticoagulation therapy. So it is important that we should give them IM. We can give them IM or subcutaneous without discontinuation of the anticoagulation therapy, and that is what we need to do. And IM administration is safe with a small gauge needle, and apply the firm pressure at the injection site. And subcutaneous for vaccine intended for IM may be associated with more local reactogenicity and diminished immune response. So these are the few things of practical importance which sometimes we need to address in our clinical practice. In cases of GBS, many of these neurological disorders appear at different ages with different manifestations. So a whole lot of these GBS and acute demyelinating encephalomyelitis and transverse myelitis, they are diagnosed at the same time as some of the routine vaccinations are being administered. So we must ensure their complete vaccination. And if we have to give them any repeat dose, so we must wait for the episode of the GBS to settle, and then we can, after that, we should complete their dosing of immunization. In cases of autoimmune disorders, SLE is relatively common, and in this, again, there is altered immune response and immunosuppressive drugs are being given. But the dictum is that individuals not being treated with immunosuppressive drugs are not considered immunocompromised and can receive routine immunization, including the live vaccines, in autoimmune disorders, because most of these diseases are these agents which are being used as for drugs for treatment, they are not immunosuppressive. So again, we must give them their annual immunization of influenza and other vaccines. But if there is some dermatological lesion, we must avoid that local area, as this may exacerbate the condition. In cases of malignancy, again, it is important to give them the vaccines, and we have to be careful with the live vaccines. And by and large, it may not, chemotherapy may lead to an immunocompromised state, and immunization should be completed before beginning the chemotherapy. Similarly, for the heart diseases, and we must ensure the pneumococcal vaccines. Other very important point is that the household members and other close contacts, including the healthcare workers of people with chronic disease, must have the up-to-date routine immunizations, including their influenza vaccines. So these are the two studies which have been published. What is the response to these routine immunizations in our nephrotics, who are especially the ones who are steroid resistant? So this was a study, and we found, this was done way back in 2013, it was published, that a higher dose of hepatitis B vaccine should be used for vaccinating patients with steroid resistant nephrotic syndrome. This one has been recently published. We took this study related to the DPT vaccines along with measles, and we found that there is a need to administer DDAP and MMR boosters in children, especially the ones with steroid resistant nephrotic syndrome. In this academic year only, I had submitted this thesis related to the type 1 diabetes and the role of what is happening to the hepatitis B and MMR status. And we found that when compared with the cases in the blue, compared to the controls, we found that the seropositivity related to HBS was low, related to measles was low. However, for rubella and mumps, it was not that bad. So therefore, we concluded from this recent study that in type 1 diabetes, we need to give booster doses for hepatitis B, and at least 2 doses of MMR should be given to these children, the ones with chronic infection. So I come back to the same thing, that I wanted to lay stress on the simple fact that these are the children who with chronic morbidity need to be given, we must ensure their hepatitis B vaccination, which may need to be repeated. Then in certain situations, the pneumococcal vaccines have to be given, the influenza has to be given, and in special circumstances, we need to give the meningococcal, and we must ensure their HPV and the DDAP and the pneumococcal 23, these vaccines need to be given. So this is what I had picked up from our Indian pediatrics, that this is what they had concluded from the publication from in Indian pediatrics by the IAP immunization committee. So when we come to this, to conclude, the MMR is a live attenuated vaccines, but can be safely given if there is complement deficiency or phagocyte disorders. Rotavirus safety and efficacy is not completely clear in immunocompromised children. For varicella, it is likely to be safe in complement deficiencies and phagocyte deficiency. So some of these vaccines, this is basically the summary of what vaccines to be used in various situations, which can be effectively given, like for DPT, in cases of should be given if there is bone marrow transplantation, for H influenza to be given, for splenectomy, hepatitis B, particularly for chronic liver disease, like I had said, and these HPV vaccine to be given to these young girls, especially the ones with autoimmune disorder, then influenza, and some of these vaccines. So the take-home message is that we must ensure the routine immunization. We must take care of immunization in special circumstances. We must immunize with pneumococcal, annual influenza, hepatitis A, B, and meningococcal. And that's where I end. Thank you very much for the.
So thank you, Dr. Sangeeta. So we have Dr. Sham Kukreja, who has been moderating this session. Dr. Sham Kukreja, you would like to say something on this aspect before we come to the second presentation?
I think she has covered this topic very, very well. I think it's a very vast topic, and within 40 minutes, she has covered very well. And I think no comments as far as presentation is concerned regarding what more can be done. But the only comment is, for example, Sangeeta, if you are using a rabies vaccine and the patient is on chloroquine, what will you do? Is it immunosuppressive or not?
Chloroquine or HCQ?
Yes, yes. HCQ, either.
You're talking about HCQ?
It's either, no problem.
Either one. Okay. Because when I had come through this literature, they said that these drugs, they do not interfere with HCQ and all. They are not immunosuppressive. They are immunomodulators. So there should not be much of an issue. Just in case, because rabies vaccine is a tissue culture vaccine.
Is Anurag there? Anurag Agarwal is there?
Yeah, he's not there on the platform.
I thought Anurag would want to,
because he has been studying rabies a lot. So I thought, because what we believe is, if you are on chloroquine and you take a rabies vaccine, it leads to some degree of immunosuppression. So we want to give additional dose.
The thing was that when I reviewed some of these immunosuppressive drugs, in that that is what they had commented upon, especially related to autoimmune disorders where they use these HCQs. So they said that they do not produce much, they do not cause immunosuppression to the extent that it will interfere with the vaccination.
I agree, Sangeeta, absolutely, except I think in rabies. We'll check up and come back to this again.
Okay.
We'll check up.
And the best part is, I would like to commend that Dr. Kukreja and myself were doing MD together, and that time also my thesis was related to these immunization aspects and how we used to discuss the results and all. So this was just going back to the memory lane.
I think
maybe in these cases we must give rabies immunoglobulin even if it is a grade 2 bite, if we suspect that the immune response will be reduced.
Ajay, I think we take it as for all bites are 3 practically, to be honest. In your practice also you have seen they're all 3.
It is very rare. Immunoglobulins for everything, sir.
Yes, absolutely.
Can I ask one question, Dr. Sangeeta ma'am? In our hospital, the cardiothoracic surgeons who operate upon newborns, they say that after open heart surgery, don't give them any immunization till 3 months. And their logic is, we always tell them that it doesn't matter, it's a T cell thymus can itself detect only T, and BCG is already given usually in these babies. So, but they say that their textbooks recommend that vaccine should be deferred till 3 months. Is there any literature on that, or any is there any issue related to this?
There, as far as our this thing is concerned, that I think. So you have asked a very specific question. I didn't look at it from that surgical point of view, that supposing if a person has, an infant has undergone surgery, and whether there is any contraindication related to vaccination. Ideally, there isn't any, because this is not related to any blood product which is going to interfere with the antibody response, whether it is T cell or B cell. So there should not be any contraindication related to post-surgery, no contraindication related to immunization as far as the scientific part is concerned.
I think anything which can contribute is a basically live attenuated vaccine. And you are not giving live attenuated vaccine till the age of 9 months. So absolutely no issue. They must change their textbooks.
You know, what I could see in the literature, Dr. Pankaj, they say no vaccine till 2 weeks. And what Dr. Kukreja has said, because most of the time blood products are used during open heart. And so that's why they say 3 months for the live vaccine.
We've got an answer from Dr. Arun Wadhwa. He says that intradermal rabies vaccine should not be given if you are giving HCQ. That perhaps
some clarification you got.
Sure. So thank you so much, and I also welcome Dr. Harish Pemde as a chairperson for this session. So we have preponed our session, but both the chairpersons, I request Dr. Sham as well as Dr. Harish Pemde to remain for the next session, which is going to be by Dr. Dhiren. So again, over to Dr. Sham to introduce Dr. Dhiren and the talk.
Dr. Dhiren is a well-known pediatrician and a intensivist from Gangaram Hospital. I think this group knows him very, very well. No need to further introduce him. I think he will be speaking on the subject of what has been happening in this current epidemic of COVID. And then we'll have discussion on COVID vaccination and COVID-related vaccination issues. And Dr. Dhiren, over to you.
So thank you. And at the outset, I would like to thank Dr. Pankaj and IAP for inviting me. I was a little bit surprised when he asked me to talk on vaccine-related issues. I mean to say, I know my specialty and I know how much I know about vaccination. Then I saw Dr. Kukreja as my moderator, so I became more comfortable. And because I thought that rather than just presenting a presentation on COVID and COVID issues and vaccination, let me change it to a little bit question answer. So we had discussion yesterday, Dr. Sham sir and me, and so what I thought that some parts will be a form of presentation and then followed by a question answer. And Dr. Kukreja doesn't know about the presentation and the question. So I want that it should come out as spontaneous answers. Especially there are many questions and answers related with not only adolescent medicine, but also with the adult one. So my topic, so today's aim, I'm of course going to talk about the basic approach in adolescent, about the treatment aspect of the COVID. Of course, some principles are applicable to adults. So we know that it's a mild, Omicron is mild, but something extra we should know. We need to be very confident when it comes to ourselves, and near and dear we need to treat, right? So we'll discuss something about what has changed in the Omicron. Of course, I will try to touch something on the rational drug uses, antiviral, monoclonal antibodies, anti-inflammatory, and the main issue which today whole discussion is, that is the vaccine issues in adolescent. We all are COVIDologists for past 2 years, what I can say. And past 3 weeks, we are listening, and got tired about Omicron. We know that it's more contagious, less severe. And in past way, we know that persistence of high-grade fever more than 7 days is usually high-risk marker. And if it is Delta, there are chances in 25% patient that there may be drop in the oxygenation, and just divide it by the 5 that is applicable to adolescents. So these are adult figures. And we all know that there was no use of favipiravir, hydroxychloroquine, ivermectin, and azithromycin. Convalescent plasma, there is no role even in sick patient. And there is some role in adolescents regarding the monoclonal antibodies. At the end of last Delta wave, these monoclonal antibodies were introduced and were given to some people who had high risk of getting into pneumonia. But the use was extended in this pandemic also. Probably it is being misused and unnecessary overused, because we know that in Omicron, there is no use of the antibodies which are available in India, that is your Cipla-1. And we all know that remdesivir used to be indicated in pneumonia, as in when the oxygen has just started. They found that there was no benefit in the mortality, and so ultimately WHO and Indian protocols ridiculed the use of remdesivir presently also, but it has again come in another form. So there is a difference between practicality, what is happening at the clinical level, and what is being recommended by the government. And we all know that steroid has got some role, especially in the pneumonia. And JAK1, JAK2 inhibitors like baricitinib were used in the previous wave in many of the patients. Now, what we want to know as a pediatrician, as a pediatric, practicing pediatrician, as an adult myself who can land up in Omicron infection, and most of us have suffered Omicron infection in this wave. So what I want to know what is the clinical behavior of Omicron and in Indian population, or is it a surrogate marker, especially means what I can say presently, COVID means Omicron, Omicron means COVID in India, and where in small cities it is the tuned of around 85 to 90%. In Delhi, it is tuned to around 95%. I also want to know, though it is looking safe, but when it comes to me, I'm anxious. I do not want to leave any stone unturned. I want to use everything available. I work in a tertiary care. Everything is available to me, and money is no problem. So still I want to see what are the predicting markers of when I should predict that my disease can deteriorate. So I want to know about it, right? And when I should start the therapy. When I should investigate, but which day? In previous way, we knew that it was around day 6, day 7. If we were persisting, then we used to investigate. Many people ask, sir, 5% delta is still there. Can I miss that delta? Can't I give monoclonal antibodies? Why to take chance? There is no side effect of monoclonal antibodies. About antiviral, like a newer drug, molnupiravir, it's not a very complicated drug. I can take it 5 days, and means I'm very anxious. I've lost my near and dear in the last wave. So what is the role of new drugs in the management? So we start with something, everybody wants to know. What is the difference between Omicron and Delta? Not much present in the literature, but based on the experience over past three weeks, around in 500, 600 patients, Omicron, if I want to describe, it is like a flu. It is actually like an influenza, not more than that. Cough is wet cough, and many patients will describe, sir, khadkhad hoti hai khansi mein, and that was not there in Delta. In Omicron, symptomatology is more than like development of pneumonia or hypoxemia. Whosoever was very anxious, they got CT scan on day 4, day 5. And in Delta, though patient had mild symptoms, but shadows were out of proportionate more. In Omicron, despite that patient is very much symptomatic during first 5 days, but shadows were almost not there in the CT scans or in the X-rays. very common is running nose, headache, and fatigue because it's an upper respiratory tract infection. So everything gets accumulated in the nose. So nasal stuffiness is very common. And very common, you look at the circumstance of an house, or at any family, you talk to them. You will find that not even a single member is spared of the infection or sign and symptom. And what has happened, your sign and symptoms have changed. It means I had around 900 online families in the Delta wave. This time, out of them, almost 25% talked to me. And this time, what was a major difference? They did not talk about the parents and the family members who suffered major Delta. They were talking about young people who were more symptomatic. When I used to talk, okay, what happened to your father? Oh, no, uncle, wo to bilkul theek hai. They're absolutely fine. This was a trend. So what I found, except the severe comorbidity like immunocompromised, the elderly population, 60 plus, actually didn't had major symptoms in most of the circumstances. Everything is relative. It can't be that 100% is applicable. So they were more anxious than the younger population. Younger population, including adolescents, has more fever and rigor especially. So nasal discharge with night sweats were commonly found in this, you can say, Omicron period. 65 adolescents, I could collect my data. And what I found that more than 100 for fever, I'm talking about symptomatic, in 80% of the adolescents. Whereas in adult, it was just 20%, this high-grade fever. And many of these patients usually have shivering. Many patients, many families describe that, okay, his fever, we couldn't note, but he was shivering. And cold, that is nasal discharge, was present in many, and mild headache was present almost in all, including sore throat. In some of the patients, especially young adults, have anorexia, vomiting. And as I told you, elderly were least symptomatic. This is a chart which explains everything. We know that once patient acquired, the incubation period in some of the patients, I found just 12 hours. Within 12 hours, they'll end up in problem, and there was no contact. So they went to immunization center, they acquired infection there. Within 12 to 24 hours, they'll end up in symptomatic COVID this time. So what has happened in alpha wave, its incubation period was 5 days, then it shifted to 4 days, now it is shifted to 3 days. So everything has shrunk. So also the asymptomatic period, that when the patient starts spreading, is of 1 day before he acquired the symptoms, right? So initial first 4 to 5 days is in a viral phase. Now the new therapies have come for this viral phase. This is a form of antiviral. Those prevent penetration in form of monoclonal antibodies. Those prevent replication in form of molnupiravir, Paxlovid, and remdesivir. And this phase is lacking, totally lacking in this present virus as compared to the Delta. Say out of 400, just around 10 patients I found there was pneumonia, and all looked at classical either superadded infection secondary to your new virus, or they actually had Delta variety. So these are the practical points I would like to have comment from Dr. Kukreja on each and every point. I'll start with, over the time, surface cleaning has almost lost its role in spreading. So very likely it may be less use of PPE. PPE, I'm talking about the hazmat suits or the apron sort of things. Only N95 mask, or at the most double mask, best of the N95, which fits onto your face, should be sufficient for the isolation where these COVID patients are there, other than ICU. What do you think, sir?
I think I agree with you, because we have gone through this process. I think in first webinar, I think you were also there, when we discussed as soon as the COVID came. We discussed a lot regarding PPE, surface cleaning, and all those things. Now we know, I think they do not carry much importance. It is basically an airborne infection. And to prevent that, you need a good mask, and N95 fits the bill.
Yeah. Second is, sir, what about this less time of isolation? Means there are no good studies. Do you feel that it is all the convenience because everybody is suffering from COVID and like an influenza? So over the time, should it further get reduced once you are asymptomatic or less symptomatic, you can join back to your work? Or if we need to watch for these patients for 10 days, or do we need to have different approach for immunocompromised or where elderlies are there? Let's have full precaution, 10 days isolation and 7 days for the young. So we have reduced from 10 days, 14 days, then 10 days, then 7 days with 3 days absence of fever, and no RT-PCR to be repeated. What is your take home, sir?
See, if there is a different recommendations by different bodies, Japanese tells something else, CDC tells something else, and our own government tells something else, it means there's no uniformity of concept. So this is less to do with science, more to do with economic reasons. Because what happens in many healthcare setups, large number of people are getting infected. So, and they are not sick. They are quite okay. Many of them are asymptomatic, or maximum they have a mild disease. So I think the combination of factors have sort of decided that it's better to work. I think CDC is saying if you isolate yourself for 5 days and next 5 days you can come back to work with mask. Government of India says 7 days, Japanese say longer time. So I feel because number one, the fear has become less. As you said in your presentation, that the disease is not so bad. It's something like flu. Number one reason. Number two, the economic reason, and less to do about the science. I think it continues to be infectious, maybe up to 7 days. And in case of maybe immunocompromised people, if they get infected, maybe up to 15, 20 days. So it's more to do with economic reason to my mind.
Okay. Secondly, in this season, I found more rapid antigen test positive, which is available very commonly in the chemist. You don't need actually RT-PCR. And on the second, third day, not on the first day of the symptoms, on the first day, rapid antigen was negative, used to be negative. On second, third day, is it something like a better kits availability, or the amount of virus in the upper respiratory tract is too high in Omicron? That's why it's coming positive. What is your experience?
I feel because this virus multiplies more, as according to the Hong Kong studies, it is 70 times more replicative in the upper airway and 10 times lesser in the alveoli. So most possibly it is the more viral load. That's the reason the rapid antigen test sensitivity has increased. And we know the specificity used to be great. It was very, very good. Whosoever is positive for rapid antigen test, we used to recommend there's no need to test, go for RT-PCR. Because the viral load is so high in the upper airways, as a result, it spreads faster, the transmission is more rapid, and the incubation period has become shorter. And also, the rapid antigen test, we used to be sensitivity of maybe 30%, has now become more than 40, 50%.
Easily, maybe higher, especially if you do on third day. Now, many people say that, everybody is a little bit anxious. Can it be Delta? Because even 5% Delta is moving here and there. And so you're a little bit scared, especially if you've got comorbidity. So some people say that to differentiate, look at the cycle threshold value on your report of the COVID PCR. And usually it's in an Omicron, it is range between 12 to 20. So very low threshold means very high amount. Do you agree, or it's all gimmick?
See, if you take the experience of the Western world, USA. In USA, the Omicron has replaced Delta to the tune of 99.5%. So I think if these two viruses compete, Omicron wins the race. So wherever the Omicron has gone, I think one of the experts in India was telling that both will circulate. This is not happening in the world. Even in UK, even in USA. I have the USA data, which was, I think, yesterday's. It says Omicron is now 99.5% plus. So it is almost replaced. So I think in our society also, in our community also, I think the same thing is going to happen. The Omicron is going to sort of dominate it. And your question that can we differentiate clinically from these? It's very tough to differentiate, even if you are given the reasons that how these presentations are, but it's very tough to decide on the symptoms because we do not have a case definition. But I can tell you one thing. The other thing is S gene loss, because one of the Omishore has come, which can tell. But problem is, there are two subtypes of Omicron. One is BA1, BA2, BA3 is also there, but these two, BA1 and BA2 was there. And I do not have a data, but I heard somewhere Dr. N.K. Roda telling that 70% is BA1, 30% is BA2. And BA2, there's no S gene loss. And in now Denmark these days and other parts of the Europe, BA2 has become dominant. So there's no S gene loss. So it is very tough to differentiate in clinical practice unless you do a genomic study.
So I will update this one. And day before yesterday, I talked to NCDC, Dr. Surjit. He said more than 40 to 50% in Delhi, it is BA2. And regarding how to differentiate, previously we used to say that in Omicron, S gene loss is there. So there are some tech path kit and they can differentiate. But now you need to have Omishore kit. Omishore kit is now available. Means yesterday it was released for general labs. They are acquiring it. And very soon, within a week, it is available. It can detect. It can differentiate BA1, BA2, and BA3. It can detect the, you can say, S gene, which is mutated, is not just lost. Okay. So very soon it is going to be available. And regarding what I found that in a room, in a house, if 10 people are there, all of them are infected without any, normalization. Means none of them is absolutely normal, uninfected, as compared to the last phase. So like in a newborn, we used to say that, okay, 6 feet difference means baby should be kept after 6 meters or 6 feet away from the mother. And when baby need to be feeded and bring it to mother, she will wear the mask and feed it. Do we need to change it? Because we know that in Omicron, this distance, especially in an enclosed room, doesn't carry any meaning.
I see it is not practical distance and all that. If the mother is managing the child, it's very, very tough. We always tell them whenever the child is near you, please use N95 mask. And that's the only thing I think we can recommend. Our distances, you must have seen in your own practice, it is very tough to maintain between the baby and the child, to be honest. Pankaj can throw light on that because
I think I want to say that this 6 feet controversy was raised by American Academy and CDC. But once it came to IAP India and NNF, then we debunked that because of two reasons. One is that the benefits of breastfeeding are too many. If you try to separate the mother and baby, breastfeeding definitely goes down. Second is the vertical transmission or even the horizontal transmission from the mother to baby. There are very few case reports. NNF is still doing a registry. And in our hospital also, we have more than 150 patients born to COVID positive mothers. Up till now, none of the baby has come positive. So that is why now we are, as such, recommendations are to room in, to bed in, but feeding should be with N95 mask. So we are not recommending 6 feet distance as far as NNF or IAP is concerned, and we are saying rooming in and breastfeeding should be continued.
I think it's a common sense.
Over to you.
Okay. Dr. Pankaj, just one request. Do we have time enough, or we should be a little bit fast?
Yeah. You have time. You have time till 4 o'clock. No problem. Continue.
Okay.
It's a very interesting discussion going on. Thank you.
Yeah. So we come to the next part. Is that what are the COVID-19 spectrum with us, and what are the treatment options? And we all know that. Can you see this green marker, Dr. Pankaj?
Yeah.
दिख रहा है? Okay.
नहीं, ग्रीन मार्कर नहीं दिख रहा. नहीं दिख रहा. नहीं रहा.
So I need. Okay. This one, this pointer.
ये दिख रहा. ये दिख रहा.
Yes, visible.
Okay. So now we come to the second part. That is, what are the various clinical presentation? We all know that most common is acute COVID asymptomatic or at the most upper respiratory tract infection, right? But the controversy rise here. The high-risk patient in the sense that who have comorbidity even in elderly, adult, and adolescent, early part of disease, first 3 to 5 days, where there is no hypoxemia, just predisposing factors which makes them high risk. When to use these antibodies and antiviral? This is the most controversial step, right? Second, regarding acute COVID pneumonia, we all know that how to recognize, how to treat. And again, in an immunocompromised patient with the COVID, what drug to be used? So we'll go through some cases, and these cases are recent ones when Omicron wave is dominating rather than the previous one. This is 17-year-old male who presented with, who received Covaxin. Many of the patients, many of the adolescents got Covaxin vaccine and land up in infection. They acquired infection during the wave, during the vaccination period. So this patient developed pain in the whole over body, especially over the chest. He was complaining of chest pain. There was high-grade fever, shivering for 12 hours. Fever was 103, 104, at times 105. Oxygen saturation dropped to 93 on day 2 during fever. And so it was just 2 days into, it must be around 5th of January. It started on 3rd, yeah, it must be 5th of January. So we didn't had much experience of Omicron, and this must be first adolescent. So I subject him for investigation because there was no contact of COVID in the family, and so I didn't suspected because patient main problem was the pain in the chest. So I subjected him for the investigation. CRP came 10, chest X-ray was normal, patient improved over 3 days, and the same day we got COVID done and it was positive. So it is not only based on this case. In the past also we have found that when patients try to take saturation during height of fever, especially more than 102, there is false low reading of saturation. Probably it could be due to severe vasoconstriction. So always look at the patient temperature, and unnecessary you can raise the alarm. This is another child, and again she presented on almost, I think, the first week of Omicron wave in India. She is a 13-year-old who presented with fever, which was high grade for 1 day. Within 16-18 hours of the fever, she fell on the floor, a toilet floor, and when she was brought to our emergency, she was in shock. We thought initially it must be vasovagal, but after 2 hours, despite of fluid boluses, her BP was 80/30, pulse rate was 120. We started on norepinephrine and we sent an antigen test. Antigen test came negative, so patient was brought to our ICU. It took her almost 24 hours for recovery. RT-PCR, which was sent at the admission, came positive, and so patient has to be shifted to the COVID ward. CRP was not negative, it was 36. Blood culture ultimately came sterile. We gave remdesivir for 5 days and discharged. Now question here arises that now we can see means we can view or reanalyze this patient. Do we need to give remdesivir in absence of pneumonia, right? And we'll see the Indian guidelines about remdesivir. This is a 22-year, again, I'll call an adolescent because her mental age is of adolescence. Means she's a regular follow-up for almost past 10 years, a very hyper mother. She is a case of multiple sclerosis, almost all sorts of problems she used to have every second month. Means some sort of, you can say, over anxiety issues are there. So she's on rituximab. She was taking my video call, and while talking to me, and she became unconscious and she became absolutely pale. So she was brought to the emergency, and when she came to emergency, I was there. I found her tachycardia and hypotensive, and we gave fluid bolus. She recovered within 6 hours. CRP was 12, symptomatic treatment was given. We did not give remdesivir in this patient because she recovered very fast, especially shock part. And this type of shock, it's not only in these kids. I've seen around 3 more patients who are, say, 54 year, 34 year, 37 year. On day 1, they became hypotensive. So this type of acute shock presentation one should remember. Now regarding this child, which I presented, and the rapid antigen test, which they took from the chemist and they perform it in their home, It was negative on day 1, but again it was performed in the hospital, it came positive. So we already discussed, because of high viral load on day 2, day 3, RAT is becoming very sensitive. Now there is another concept coming about the saliva. Saliva, in many of the studies, they say that it is almost 100% sensitive as compared to nasopharyngeal swab. So probably over the time, when kids will be standardized for the saliva, practice may change, because Omicron, they feel that it gets excreted more in the saliva than the nasopharyngeal secretion. This is another 13-year-old, a case of Down syndrome. He's a regular follow-up as a case of chronic lung disease. He's on 2-liter oxygen for past 4 months, on steroid for 2 months. And this patient developed fever, cough for 2 days. There's no exaggeration in symptoms, respiratory symptoms. But this patient is receiving high-dose steroids, a case of chronic lung disease. COVID RT-PCR positive. So should we hike up the steroid, or should we give remdesivir in this patient? I didn't hike up the steroid because it must be viremia phase, but I do subjected the patient for 3 days remdesivir. This was the condition of the patient, right? Now, this is a 3-year-old, not adolescent, but worth sharing this patient, a 3-year-old B-cell leukemia. He's in reintroduction chemotherapy, 4th week. So past 4 weeks, patient was receiving dexamethasone, and every week he used to get chemotherapy over dexamethasone. So routine screening, COVID came positive. Patient received chemo in the COVID ward because patient was COVID positive. After 3 days of, say, receiving this chemotherapy, patient presented with the shock and vomiting. The patient landed up in shock. This, you can, just a minute, I'll show you. This is a patient. When patient came, patient was given antibiotic, required inotrope. It was a refractory shock, required ventilative support. No organism was detected. No remdesivir was given in this patient. And 5th day patient also recovered, was out of, shock and also from the ventilative support. Now question arises, this is an immunocompromised patient, didn't have pneumonia. In the previous 2 patients, despite that they must be having Omicron, we are thinking that they must be having Omicron, but they didn't have pneumonia. So what is the indication of remdesivir? Steroids, anticoagulant in children and adolescents. So this is a difficult question to answer. When you are dealing with a very sick patient, you try to give everything. So what are the Indian guidelines, which were published around 48 hours back? They say that there is no role of remdesivir at all. They didn't went into subgroup analysis, but they said no role of remdesivir in less than 18 years. And regarding steroid, whenever there's a respiratory involvement, pneumonia is there, you can give dexamethasone or methylprednisolone for 5 to 14 days, depending on the clinical assessment. These are the WHO recommendation, and they vary from NIH or CDC recommendation, and where they clearly said that the remdesivir is not indicated, hydroxychloroquine, lopinavir, ritonavir, ivermectin, all these drugs are absolutely should not be given. And in a patient with severe critical pneumonia, systemic steroid, tocilizumab, and monoclonal antibodies, if you're thinking of non-Omicron variety, you can still use it. And of course, they also feel that without hypoxemia, steroid should not be given, convalescent plasma should not be used. So what do you think, Dr. Kukreja, why these things are varying? I mean, CDC says that, okay, you can use remdesivir if patient belongs to high risk group, and look at our adult colleagues, and they are using remdesivir in high risk group, right and left, even despite that WHO says no, Indian authority says no. So why this remdesivir is going up and down? And what do you think that suppose your near and dear gets pneumonia and not pneumonia, but gets COVID, they immunocompromised, on 5th day fever is not settling. Would you like to give remdesivir or not in your personal practice?
Let's put it like this. In my practice, I've used remdesivir only in one patient, and that is similar patient of yours. I think we used about 4 days ago. And this was a patient of MS with he was on rituximab, the girl child, about 12 years or 13 years. And she has been receiving, because she has a repeated episodes, and she has got a lot of steroids also. So we gave 3 days of remdesivir, to be honest, only in one patient so far. Now your question, what is the status of remdesivir? I think it is a legacy issue. In case of Delta, it was something of clutching onto some straws. We were having so much of illnesses and all that. We have not done no one has done a study in India to feel what is but every physician was telling, particularly people from Mumbai and other places, they were telling. So since remdesivir has come, they have seen less morbidity. But to be honest, there's no study like that in India. As far as the Western world literature is concerned, now remdesivir is being recommended. Earlier it was being recommended. I think you were there in that webinar.
Yeah,
It was being
I've shown that study.
Yeah, it was being recommended as soon as there's an onset of hypoxia with steroids.
Yeah.
Now the recommendation is if you want to prevent the progression of disease, you may give remdesivir. I think CDC, if I'm sure, is giving it, and they say the morbidity reduces, hospitalization reduces to the tune of maybe more than, I think you're showing it, more than 87%.
Yes.
But somehow the data in children is very scanty, and it is being recommended in bigger children, but some people have used in smaller children as well. But as far as in my practice, we have used in one child in this season, and that was the patient I telling you.
Yeah. So remdesivir can be given in any child weight more than 3.5 kg. But look at this new avatar of remdesivir. First 7 days, if there is patient belongs to very high risk group and disease is uncontrollable, you can give for 3 days without oxygen requirement, means without establishment of pneumonia in a very high risk group. So this is, you can say, a new avatar of remdesivir which comes and goes, and but definitely it's better than the oral drugs which are available like molnupiravir, and unfortunately we don't have flexible. But good point about this Omicron, the severity is so less. Probably drug like molnupiravir, means I mean to say that doesn't have any meaning. If it would have been Delta wave, then probably our thought process could have different, because molnupiravir, they said that it's a 30% benefit, 30% is quite a bit. But looking at the Delta, the severity of Delta, definitely then it would have been worth trying. Now we move to the monoclonal antibody, just one slide, because our main part, that is vaccination, is still lacking, is still there. Now monoclonal antibodies, just want to inform that our reagent antibodies that is available in India, that is our Cipla, which is distributed by Cipla, Roche. There is no role in Omicron, and when 95% is reagent, the Omicron, then it should not be used. It is being misused and unnecessarily being given. And the monoclonal antibodies which is not available in India, that is sotrovimab. This is 500 milligram infusion, can be given in adolescent also, as based on the COMET-I study. They said that 85% relative reduction in Delta, but they did plasma study, sera study, and found that Omicron still have got, in Omicron it has got some role. Now we move to the last part, that is of the treatment. For pneumonia, we all know that steroid, anticoagulant. Now, role of anticoagulant has gone down unless patient is actually requiring high oxygen. That means oxygen requirement is pretty high. You don't use anticoagulant. And JAK inhibitor like baricitinib, everybody has used in the Delta wave. So it has also been recommended by the WHO. And a patient who has had severe COVID during admission should be given anticoagulant for 4 weeks on the discharge. And tocilizumab can be used in severe hypoxemia. Now we come to the main issue, that is the vaccine issues in adolescents. So Dr. Kukreja, as you know, as a father of an adolescent and also a doctor who knows COVID little bit, may not know a lot of vaccination issues, I know that in adolescent and pediatric age group, this disease does not carry a lot of morbidity, mortality. Vaccine-induced myocarditis, I have heard in mRNA vaccine, like 58 patients or in 10 lakh, the 5 patients are there. And vaccine doesn't prevent any human to become contagious. So still he can acquire the infection, he can spread to my house. So why we need to vaccinate pediatric age group?
Dhiren, this is the toughest question in this vaccination of COVIDs. See, we know the morbidity is and the mortality in children is very less. We know that. If you see the WHO data, it tells that 0.5% of all global deaths because of COVID are in the age group which is less than 25 years. It means 99.5% of the mortality is after the age of 25 years. So that's the interesting data. So we are dealing with a very condition in children which is very low morbidity, very low mortality. So this is one. And second is, you absolutely hit the nail on the head. Vaccine-induced myocarditis, if you take the Pfizer vaccine, which is reputed to be the best vaccine, or Moderna vaccine, which are RNA vaccines, and reputed to be the best. The problem is, if you see the latest Kaiser Permanente data as compared to CDC data. Now, CDC data says it's quite rare and all that, everyone has read it. The Kaiser Permanente is a healthcare provider in California and many parts of the world, in many parts of USA. And they're also the insurance company. So they have analyzed the data where the people got admitted, even non-Kaiser Permanente healthcare providers place. So they, according to them, the data is very similar to Israel. The incidence could be even less than 1 in 5,000. Although many people recover, most will recover, but the myocarditis part is there. There's a morbidity. Is this morbidity more than caused by the COVID? Yes, it is more than caused by the COVID. So there is a need to have a vaccine which is very, very safe. If there is a disease which is not going to cause much of morbidity and mortality in children, so you need to have a vaccine which is much safer than that. So in elderly, just go back to the Delta wave, where there was 20% people needing oxygenation or hospitalization and many landing up into ICU and dying. In those situations, if the vaccine has got some degree of side effects, this will be accepted. It's okay. But where the disease is very, very mild, in those cases, I can't accept this myocarditis. So that way, we have a safer vaccine in India. We can discuss later on.
So you mean to say, in nutshell, we need a very safe safe vaccine, especially when it comes to pediatric, because the disease is disease doesn't have that much side effects, or you can say complications. So yeah. So drugs should not become Dracula, right?
Even Dhiren, you can tell your experience. How many of patients even in Delta wave, which was a very deadly wave, how badly the children were affected as well?
Yeah, they were very few. And I'll just quote your data, what you presented, that in the WHO, they say that what is the burden of disease? Older children and young adolescents, 5 to 14, account for 7% of reported global cases, 0.1% of reported deaths. And older adolescent and young adult, that is 15 to 24, and you rightly said it is just 0.4% of the reported global deaths. Now, probably the problem is only that the milder symptom, and children are tested less, they are less reported, and we have seen the cases of MISC, those patients of MISC, almost 75% used to suffer asymptomatic COVID rather than symptomatic COVID. Now, again, the burden of long COVID-19 in form of prolonged fever, unmasking of tuberculosis, that used to be the commonest manifestation post-fever, post-COVID fever, prolonged fever in adolescent and pediatric age group, that the incidence we don't know. And another point, there is some data coming from US and from Germany that your vaccination in adolescent can prevent MISC. Do you feel that the data is robust enough to apply, to be applicable in Indian population where Covaxin is available, or we need actual data from Indian population?
I think we have not heard the last word regarding the last, because we do not know. For example, if you take any patient who has been even vaccinated, they still get the infection, breakthrough infections. So once they have got a breakthrough infection, will they have later on MISC or not? I am not very sure about it. So,
Yeah, so
what is the basic mechanism? It is not well understood.
Yeah,
So what leads to this? So I think we need to learn, we give some time, particularly after Omicron, that what happens regarding MIC cases. I think already 3 or 4 weeks have gone by. We have not seen because it happens between 2 to 6 weeks, most of the cases. So we have not seen MISC in my practice, a single case in last 1 month. What's your experience regarding that?
Yeah. I just happened to see one case in Lucknow with MISC around 3 days back. It was not MISC, it was just in fever, that is febrile inflammatory state, but post-COVID. Okay. Around 4 weeks post-COVID. So we don't know. Let's see. And the same paper of WHO says that what is the role of children and adolescents in transmitting SARS-CoV-2? Children of all ages can become infected and can spread the virus to others. And I've taken statement as such. Adolescents test positive for SARS-CoV-2 at a higher proportion than the young population. So adolescents can transmit more. And a symptomatic adolescent, levels of SARS-CoV virus DNA means which they shed the virus in the respiratory tract appear similar in children, adolescent, and adults. So they did not find any major difference. Means if an adult can transmit, pediatric age group can also transmit. This is a very important and strong statement, that is socio-economic impact of the COVID-19 pandemic because of the adolescent and children getting affected. They say that there is an emotional stress, distress, and mental health problem. We all know, we have witnessed this. Vitamin D deficiency, people have become obese. They are more prone, kids are more prone for maltreatment, sexual violence, adolescent pregnancies, and child marriage. They have quoted that in many places these are happening because of kids not going to the school. And also there is a cyberbullying because kids more on the laptop, on the iPads. And they found that 24 million children are at risk of not returning to the school owing to the pandemic. So even if pandemic goes away, this number of population is not going to come again back to the school. And they have estimated 10 trillion loss in lifetime earning. So also they said that routine immunization services has been negatively affected, and we may find resurgence of measles, tetanus, yellow fever, HPV, and other infections. So these are the, you can say, indirect negativities because of pandemic which is happening and schools not opening. So probably they have got their rationale for vaccinating adults and children, that especially in the alpha wave, not in the delta, the risk of symptomatic cases in the household contact of a vaccinated child was 50% lower than among household contact of an unvaccinated. So if your contact, if the vaccination is done, and then there are less chances of getting the COVID infection. And also if you vaccinate them, so there are less chances in household, that 50% chances less that it will come to your house. And also they have found that it will minimize the school disruptions and comorbidity, especially in immunocompromised, steroids, splenectomy patient, diabetes. The previous speaker has rightly elaborated these immunocompromised conditions. These patients should definitely get COVID vaccine. And very important, it may be just a confidence building. Many parents feel that even if it doesn't work, if even your vaccine is not very much required, but they feel very less confident that how we can send, we are vaccinated, our kids are not vaccinated, how we can send them to the school. So regarding type of vaccination, Covaxin is only available. We know that there is a safety data, and out of 526 patients, they have found that the antibody response is 1.7 times of the previous adult Covaxin data. March onward, probably it will be indicated in 12-year onward, not just limited to the 15 to 18. And we all know that Covaxin is probably the safe and it's not very effective. Now, what we want to know, Dr. Kukreja, what are newer vaccine in your thinking that is going to change the scenario in the India? I see 3 slides on the newer vaccine, and you can comment on that. Do we need variant-specific antigens in the vaccine like in influenza? Can we have better vaccine which can prevent the infection spread, like nasal vaccine? So, what do you feel that what is going to be the future of COVID vaccine for pediatrics? But what I found that this BBV154 nasal vaccine trial, which is going on and has been given for the phase 3 on the 5th of January by the Bharat Biotech. What do you think, sir?
Before I come to these questions, Dhiren, in your presentation, you have raised 2-3 issues. One is value of vaccination in adolescents. I think the most important point is the older children, they behave more like adults. So they need to be vaccinated. If you see the data of all children, including adolescents, I think more than 14, 15 years, they fare badly as compared to younger children. So it is very important that more than 12 years should be vaccinated. I'm not very keen to straight away starting vaccination less than 12 years. And when you have a lot of data, particularly the short-term data that crores of people have been given vaccine, you develop confidence in that vaccine, thus yes, it can be used in children. So I agree with you that Covaxin is quite okay that way. It's on a very established platform that this is a killed vaccine, and we have used a lot of killed vaccine in our practice, and you feel very confident regarding this. Messenger RNA, others, we do not know what is going to happen long term, although so far the data is very soothing that it's not going to create long-term problems. But still you have a 0.1% question in your mark that I'm giving to a young child. So you don't have a long-term data, you have a short-term huge data. Now coming to the other point, I think which is a very important question in today's context, even it includes the girl child also. Now, school-going children, for example, I think they are being harmed a lot, but not going to school. The health risk of children by COVID is absolutely minuscule. We have discussed that. So I think we all as a IAP must recommend that the school must be open. And many times mothers come to me and they tell me, sir, COVID ka vaccine aa jayega to uske baad dekhte hain. So I discuss with them, show me your vaccination card. Even DPT is missing, MMR is missing, chickenpox is missing. So I tell them these are more deadly diseases and you are worried about the COVID, which doesn't make sense to me. So it is very important, which you have raised in your presentation, that they must be asked to vaccinate with the existing vaccines first. And then definitely the COVID vaccine maybe after the age of 12 years. And our government has been very, very good in planning that first adults, elderly, and then coming healthcare workers, and then coming to younger age group, and now going on to 12 to 18 years. That's a very, very sensible approach, and I endorse that. And now coming to your question, regarding future of vaccination, I think vaccines, one thing they have not been able to do, which is a bigger deficiency of vaccines. They have done wonders as far as reducing hospitalization, reducing mortality is concerned. All over the world, this data is there. But one thing they have not been able to succeed is the transmission. And I think vaccinated people who are more than vaccinated for 3-4 months, even the people who are booster dose, even after 10 weeks, they keep transmitting the infection. So the chain of transmission is not inhibited by the vaccination. That data we have. So if you say the child is going to the school and usko vaccine lag jayega to wahan transmission nahi hoga, ye unfounded hai. Transmission to school mein hoga. Lekin ye alag baat hai ki the children are not going to get affected in a bad way. So the people around school who are working there are elderly and others, they must be vaccinated. The people who are sending children to the school, their family should be vaccinated. particularly immunocompromised, and all elderly must be vaccinated. So it's very, very important that way if we want to open the schools. And I am very keen that the school must open. The children are going everywhere. They're going to markets, they are going to places, play schools in their vicinity. They are going everywhere. They are going to the malls, playing in the gardens, but they are not supposed to go to school, as if the school is going to give the infection to the child. So this is important. Coming to future of vaccination in children regarding new vaccines. Regarding new vaccine, I think we are going to have a vaccine which is Covovax, which is soon going to come. Then Corbevax, which is soon going to come. These are again an established platform. It is similar to hepatitis B. In hepatitis B, you have a HBsAg antigen which is being produced by the yeast. Here also, the spike protein are being produced by the bacteria. So you are giving ready-made spike proteins, and the data so far indicates that these vaccines are very immunogenic as compared to our Covaxin and Covishield. So I'll say, and they are on a very established platform also. So this is one, to give these vaccines, and this time the Omicron was very safe, sort of a not a very bad disease. Tomorrow you may have a variant which can be a very dangerous one, as bad as Delta. So in that situation, I think vaccinating with such type of vaccines to the population and to children is very important for the future. So any vaccine which can prevent transmission, we need to have a good vaccines. But one of the vaccine which is supposed to be promising is a nasal vaccine. Now, nasal vaccine is again a live attenuated type of a vaccine. Is it going to succeed in preventing transmission? That is to be seen, but this looks a very exciting project. Do we need variant-specific antigens in vaccines? I think it's a race similar to influenza, very similar to influenza. You are suspecting that this is circulating today, influenza strain is circulating, and tomorrow it will be needed. By the time you have a vaccine, many times it may not match. Most of the time it matches. So we have to, I think, go on the lines of influenza if we really want to sort of catch up with the changing strains. Do we have, but in this situation, because the virus is very rapidly spreads, you need to have a timeline not of 6 months, maybe about 2-3 months. And RNA vaccines are capable of, I think, 2-3 months, they can be made new. I think currently they say they are not making it because they have a lot of backlog, economic reasons are there. There are a lot of backlog of, I'm not very sure about it. They say there are a lot of backlog of old vaccines. So they want to first consume that, and then they want to bring the variant vaccine. I don't know how far it is due. Now coming to 3, can we have vaccine which can prevent infection? I think we have discussed that. Nasal vaccine looks a very exciting project that way. And can we make a vaccine out of a nucleocapsid? Because nucleocapsid is similar in all the variants. It is spike protein which changes more rapidly. So can we have a vaccine based on this nucleocapsid? So I think if you make a vaccine on the base of nucleocapsid, maybe it can be a vaccine for future variants as well, as we are thinking of protein-based vaccine in influenza.
Yeah, so there was article I have read around a month back. There's a super antigen-based vaccine, and that can answer for all sorts of mutations. One point is very confusing because you are vaccine expert. I just want to discuss. I've read that for disease severity prevention, you required some amount of antibodies and T cell. These two helps. If you want infection prevention, means getting into the body, you require very high amount of ready-made antibodies, which will prevent the infection penetrating into the body. So our vaccines, say whether it is you can say Covishield, Covaxin, and it does not mount that high antibodies response. So is it the reason that they are not able to prevent the person to become contagion? So
yes,
that's why we require nasal.
I think Dhiren, you are right. To prevent a symptomatic infection, you need large amount of antibodies to prevent the infection. To prevent the severe disease, you need activation of T cells. Now it has been seen, even if the new variant of Omicron has come, the 20% of the epitopes have changed, but 80% of the epitopes are similar.
T
as
cells,
compared
for
to
T cells.
previous one. So what happens? The T cells have formed against these 80% epitopes. So as a result, so your adaptive immunity is preserved. For example, I give you an example. For example, in a outbreak of measles in an area, we say you can even vaccinate at 6 months. Okay. Now, what happens if you give it at 6 months? The children do get infection because of measles, but the mortality is reduced. So what happens? This vaccine, after it has been injected, in these cases, is not able to mount a good antibody response because of maternal antibodies. But the T cells are formed. Because the T cells are formed, they don't allow the babies to die. So this is the logic in measles. And the similar logic is there. Even if the spike protein, a lot of changes have occurred as compared to Wuhan virus in this Omicron. But the T cells to these small antigens, all these epitopes have formed. And the 80% are still preserved in Omicron. That's the reason you are not dealing with a naive population. You are dealing with a population who have been exposed to these epitopes, and they have some T cell antibodies.
Yeah, Dr. Kukreja rightly said. One more concept I have heard, that lesser the incubation period, lesser chance for the immune activation like T cells. So that's why your vaccination failure chances are very high if you don't have very high amount of antibodies, if you're dealing with any infection who has got very small incubation period.
Absolutely, absolutely. Because, for example, even in influenza, the incubation period is just 2 or 3 days. So in those situations, you need ready-made antibodies, and that's the reason you vaccinate every year. Will this happen in case of COVID? We do not know so far, because the data is coming. If you give more and more boosters, it leads to hypersensitization. So what will happen, I'm not sure. But one thing which is very good about the vaccines and which has done wonders, it has been produced in a very short time, one, and two, it has definitely reduced hospitalization and deaths.
So you mean to say very good high amount of antibodies is like a cash available to you, and T cell is like a fixed deposit, which will come little bit time. It will take time.
And
right?
that's the reason the role of monoclonal antibodies. You're giving a ready-made antibodies against 1 or 2 epitopes, and that is what you are achieving. You're just destroying the virus straight away.
So we are actually encouraging the black money, right? Now we come to the few of the new vaccines which are due to come in the market. That is, one is Zydus Cadila COVID-19 vaccine. Friends, you will be amazed to know that this is the first vaccine which has been approved and tested in pediatric age group. Just 3 minutes I will take. I will be finishing. I know that 10 minutes are left. So, but unfortunately, what has happened? This is a DNA plasma COVID-19 vaccine. So this is a very new platform. So, and also required special injector that also costs you something 30,000, something like that. So that's why the government is not actually ready to, start with the pediatric vaccination with the Zydus Cadila COVID-19. And this is why we need it, why we need these type of platform. The good point about the DNA plasmid based vaccination is that they do not require adjuvants, and they produce antigen over long periods. So they may be a vaccine for the long term, right? And also that a cell mediated immune response is not evoked by your attenuated and killed vaccine. So that's a major difference between a live attenuated and killed vaccine, at times not able to evoke your cell mediated immune response. And that's why the benefit of this DNA plasma based COVID-19 vaccine has come into the role play has come into the actual utility. And also DNA vaccine, as per them, means Zydus Cadila website, and especially for immunocompromised, this can be game changer. And this way, this is an intradermal injection is given. The intradermal injection is given by spring powder jet injector. So this is required. Why this is required? What happens? Your DNA vaccine has to not only has to enter the nucleus, so it has to traverse through 2 plasma membranes. One is nuclear membrane and second is the cellular plasma membrane. That's why you require special injector and special way to inject it. And efficacy, all these has been tested during Delta time, not during Omicron, was 66%. And this was the first vaccine which was approved in July 2021 for 12 to 18 years. And the 3-dose schedule is there. This is another vaccine which everybody feels is going to be the game changer because they induces antibodies almost equivalent to our mRNA vaccine. And this is a Novavax COVID-19 vaccine, subunit COVID-19. They said that this is something like a recombinant nanoparticle vaccine. It is developed by Novavax and with collation with Epidemic Preparedness Innovation. This is an institution. And efficacy, again, not Omicron, but in a Delta and previous one, 83% around and 89% after second dose. The good point is that doesn't require storage. It has got lipid nanoparticle and that gets formulated into a saponin-based matrix. That is a patent of a Novavax and is given in the 2 doses. And they have found it is very effective and pediatric extension of phase 3 trial is being done on the 3rd. Now it has been given approval in December 28th. It has been given approval. And also the government is allowed to enroll 7 to 11 years for Novavax COVID vaccine trial. This is another vaccine, COVID-19 vaccine, that is Carbovax. And this is something like which we know for years, like hepatitis B, recombinant hepatitis B, how they are produced. You just need a protein yeast fermentation and you get your S antigen, and this way it is very safe. And good point about it is a non-patented, means Texas Children's Hospital and these colleges has developed it, and it is going to be non-patented. So in India, Biological E is going to develop it, and the cost is going to be very less. And this is a DGCA approval on 28th, 29th of December. So I conclude my presentation and thank you, Dr. Kukreja, and for helping me, especially on the vaccine part and the management part. Disease spectrum is shifting from elderly to adult and to young adults, especially symptomatic disease. We don't know which type of wave is going to come next, and this has posed a lot of surprises to us for the past 2 years. Omicron, we know that is mild. You actually doesn't need any treatment. Even with comorbidities, you just wait for 4 to 5 days. It goes away. You don't need monoclonal antibodies. You don't need remdesivir. No use of oral antiviral like molnupiravir or Paxlovid. And probably if we try to inhibit a benign virus, it can lead to more mutation. My feeling is that it is something like you give unnecessary antibiotic for good microbiota, which is present in the intestine. You're going to induce mutation and you're going to pose a resistance in them. And of course, child vaccination is must for the future, and we need a very safe vaccine. And I always say that this Omicron barks more than it bites. And thank you. Thanks for the patient hearing. And thank you, Dr. Kukreja, sir.
Thank you.
Thank you.
Thank you.
So, thank you, Dr. Dhiren, for a lovely and a beautiful presentation, and Dr. Shyam for your inputs. I have a few questions, Dr. Dhiren, if you can feel free to. One is that you said that for the Omicron, the saliva is more important rather than the nasopharyngeal. But the RT-PCR still, which is being done, is done from the nasopharynx. So you take on it.
Madam, practice will change. Practice will change gradually because the kits has not been standardized for the saliva. That is the only limitation. Somebody asked that, if you inhibit the virus, mutation will be less. But the type of inhibition, the type of antiviral drugs which are, inducing, if you look at the molnupiravir, it induces mutagenesis in the virus. So it is said that if you don't take full course of the antiviral, it can induce mutation in the virus, and in future you can get more mutated viruses. So it's not very simple that they all will get inhibited. There can be some partial inhibition and mutation we can induce.
And secondly, since it is the incubation period is less, what is the ideal time for getting the RT-PCR in this wave of Omicron?
Yeah, once you're symptomatic, you can get an RT-PCR on day 1, but for rapid antigen test, it's day 2 to day 5.
All right. And what is your take on the use of JAK inhibitors in adolescents for?
Yeah, they have been indicated 12-year onward, but again, as I told you, that in the present wave, virus itself is so timid or so less virulent that normally JAK inhibitors are required in a given patient where steroids are not working or very high dose of steroids are being used. So you use JAK1 and JAK2 inhibitor. Baricitinib is most common, 4 milligram once a day for 14 days or till the patient is discharged. So we have used in adults, not in adolescent or pediatric age group, but it is indicated 12-year onward.
Secondly, I wanted to ask the role of taking the pulse oximeter. Sometimes in these children, it doesn't pick up. So the parents are always apprehensive.
We have stopped asking the parents to check the oxygen saturation, especially during this pandemic.
So what red flag markers should we tell them that when they have to approach us for this particular wave?
I mean to say these are all general markers which pediatricians know. There is nothing specific marker for the COVID one, but one major marker which is applicable to everybody. If fever is persisting beyond 5 days, what I have found that there were alternative causes of fever rather than Omicron or its complications in the present wave.
Absolutely.
Right. And there's one question in the chat pops that if suppose someone has suffered Omicron during this wave and they are due for the precautionary dose, what is the ideal gap? Is it 4 weeks, 6 weeks, or 90 days?
3 months. 3 months.
3 months.
And I would like to just convey one thing. Just wait for 3 months. We look at the situation there. What are the vaccines available? Which is the best vaccine to be given as a precautionary? Secondly, this is my message. Look at the West or South India. When the COVID strikes there, within a month, it is going to come in the North India. That is the time we should take precautionary dose, because these COVID waves are will come and go, right? What we want, you take a COVID vaccine, around 4th week, it will peak the best benefit. So if we coincide that peak, this present the precautionary dose, it we are fortunate that Omicron turned out to be very light. Otherwise, the 10th of January probably was not the right time to announce for the precautionary dose, because you are going to acquire infection when you are going to get this injection or vaccine in the vaccine center. And the same problem happened during second wave. Many people acquired Delta wave due to overcrowding of the vaccination center. And probably we should have vaccinated. We should have started this precautionary dose at least a month back, that is around 15th of December. And we knew from the November 22nd that it is going to come in India also.
Thank you, Dr. Dev.
That's another point. Does the booster dose work or doesn't work? That's another point.
Yeah, that is so.
Before I hand over to Dr. Deepa Pasi for formal vote of thanks, I have a couple of announcements to make to all the IAP Delhi members. One is that the monthly meeting of IAP Delhi is going to happen on 27th. Normally it happens on 20th, which is the third Thursday. But this time it was Padicon and we never imagined that Padicon will be postponed. So we had kept it on 27th. So I welcome all of you. This is going to be in collaboration with VACCINATION Delhi IP program. We have one lecture and there are 3 case presentations by Gangaram Hospital, Balaji Hospital and Agrasan Hospital. So welcome you to that. There are 2 more programs which are being done in liaison with the one with North Delhi, which is on Republic Day. We are trying to celebrate Republic Day by singing some songs and some dances, performance and all. So we'll be sharing that link also today itself, today evening or tomorrow, so they can join us on Republic Day celebration. And third is Dr. Ajay Gupta, East Delhi IAP is also planning to do a Zoom meeting in which reopening school is being discussed. That is going to happen on Friday. So all these links will be with you very soon, one by one. So I request all of you to join all these programs for better functioning. And now over to Dr. Deepa Pasi.
Thank you, Dr. Pankaj. At the outset, I'd like to thank Delhi IAP for giving us this opportunity to be associated with you. And it's a great platform to be associated with the esteemed faculty. Thank you, Dr. Shyam. You're always a treat to hear. And Dr. Dhiren, your presentations are too good and very informative. Dr. Sangeeta for giving us a very, very lucid talk about the vaccines and the comorbidities. And the take-home messages, I would like to say that, is Dr. Pemde around? Has he come?
मैं तो इंतजार करता था क्या?
He's there.
Is he around?
Yes, he's
Yes,
there.
I am
He's just-
We should have the expert comments from Dr. Pemde.
No, I could not listen to Dr. Sangeeta Yadav, madam, which was the
Sir,
supposed to
then
be
your
second
comments you
lecture.
have heard Dr. Dhiren and Dr. Shyam.
No. I think no comments are required. It was so self-sufficient talks by Dr. Dhiren and Dr. Shyam Kukreja, sir. I think nothing else is required. Thank you very much.
Thank you, sir. Thank you for your input. Secondly, the take-home messages is that the schools should be opened as soon as possible because there's a lot of mental health issues we are seeing in the adolescents. And to prevent that, we should always take an opportunity to guide the parents for the vaccination and also for encouraging them to giving permission for the school opening. With these words, I will take your due. And Dr. Deepak, if you want to add on to something, Dr. Pankaj.
Yeah, I just want to say that these talks which we have heard today, for wider knowledge of everybody, these talks will be uploaded on the IAP Delhi platform in another 48 hours. So those of us who have not listened to the complete talk, or those of us who as friends have not listened to, can see them on IAP website. Yeah. And over to Dr. Deepak, please.
Yeah, I just want to thank everybody and request for the future support. Like today's was an excellent talk, excellent program, and I am very happy. My first program, tenure of my first program was such a brilliant program by Dr. Dhiren Gupta, Dr. Shyam Kukreja, and Ma'am Dr. Sangeeta Yadav. So, शुक्रिया और आगे के लिए साथ की तमन्ना रखते हैं. Thank you, Dr. Latika Bhalla.
धन्यवाद.
You want to say something?
Thank you, Ji.
Thank you very much.
Thank you very much.
For the
Thank you.
opportunity.
So
Thank
let us
you
all
all for
pledge
your-
to save the girl child on the Girl Child Day. Thank you so much.
Thank you.
Okay, bye.
Thank you. Bye-bye.
Thank you.
Thank
Bye.
you. Bye-bye.
थैंक यू
थैंक यू.
Bye.
वो जो है ना, आपको क्या करना है, आपने इस जो इसकी छाती में दर्द आता है उस छाती का निकाल